welcome to the ASCO Guidelines podcast, one of ASCO's podcasts, delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. John Gordon from University of California, San Francisco, lead author on Systemic Therapy for Advanced Hepatocellular Carcinoma, ASCO Guideline Update. Thank you for being here, Dr. Gordon.
Of course. Happy to be here.
Then before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Gordon, who has joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So then to jump into the content of this episode, first, Dr. Gordon, what prompted this update to the Systemic Therapy for Advanced Hepatocellular Carcinoma Guideline, which was last published in 2020?
So both the initial guideline in 2020 and then the update now were really driven by advances in the standard of care. So the original 2020 guideline was actually held for a little bit so that we could incorporate the availability of atezolizumab plus bevacizumab, which just reported back and then received FDA approval during 2020. And so we were happy to be able to provide what was a very timely update to clinicians about being able to use that new regimen that had really changed the face of therapeutics for advanced HCC. The update was driven again by a shift in therapeutics, and really specifically it was the presence of much more evidence for the use of combination CTLA-4 PD-1 or PD-L1 immune therapy strategies. So the primary thing was the availability of durvalumab plus tremelimumab, which was studied in the so-called HIMALAYA phase 3. And so the key shift in this guideline was being able to incorporate those data as a second first-line option. Furthermore, when the 2020 guideline was released, data were just becoming available about the combination of ipilimumab and nivolumab, and so were not covered in any great detail. And so we wanted to be able to be sure to incorporate both of those regimens, which we thought were quite significant in the current therapy for advanced HCC.
Appreciate you providing that background on the evidence informing both the original guideline and this update. So then next, I'd like to review the key recommendations of this update. So starting with what is recommended for first-line therapy?
So the current recommendation in the first-line setting is to offer patients either atezolizumab plus bevacizumab, sometimes called atezo-bev, or durvalumab plus tremelimumab. At this time, those two regimens were not able to distinguish between them based on the primary evidence available, but there are a few distinctions in the studies and the patients that physicians may wish to consider. So in particular, because atezo plus bev contains an immune therapy and then an antivascular agent, for patients who are not eligible for antivascular agents or for whom an antivascular therapy might be of higher risk, for example, people with a history of esophageal varices or people with peripheral arterial disease, we would encourage physicians to preferentially consider durva plus tremi. Similarly, for patients where reactivation of an autoimmune disorder is of particular concern, staying away from the more potent immune combination is also advised. But again, the data themselves support the consideration of both. And then it's really up to the provider, their multidisciplinary team, and then communication with the patient around what is optimal for that patient. In addition, in a frontline setting, it is advised that for those patients who are unable to receive atezo plus bev or durva plus tremi, sorafenib and lenvatinib, the traditional tyrosine kinase inhibitors that were more commonly used prior to 2020, may also be considered in the frontline setting. And furthermore, for some patients, it's also reasonable to consider the use of durvalumab alone, which is the PD-L1 inhibitor component of the durva-tremi combination.
Understood. It's helpful to understand which regimens are optimal for which patient population and options that are available for shared decision-making between patients and their clinicians. So then following those recommendations for first-line treatment, what is recommended for second-line therapy?
One of the things I want to be clear about the second-line recommendations is that these are largely driven by expert opinion rather than primary research studying the use of these agents after either atezo plus bev or durva plus tremi. So if you look at the history of HCC drug development, 5 or 10 years ago, when we were confined to the use of sorafenib in the frontline setting, many studies explicitly studied the second and later line population. But in the current era, where new frontline therapies have supplanted those agents, it becomes a little bit harder to provide a truly evidence-based answer. And as a result, the recommendation is, frankly, to consider all of the options of FDA-approved agents. And just as was the case in the frontline setting, to balance what might be sort of patient-specific characteristics, both in terms of comorbidities and also ability to adhere with these regimens, which are not the easiest. All of those things should be considered when opting for a second-line agent. But just to sort of be slightly more explicit about it, for those patients who've received frontline atezo-bev, the considerations would be either transitioning to a tyrosine kinase inhibitor, most classically sorafenib, lenvatinib, or cabozantinib, or in principle ramucirumab, the biologic antivascular agent, or a CTLA-4 PD-1 or PD-L1 combination, such as durvalumab or nivolumab plus ipilimumab. Conversely, for those patients who might have received durva-tremi in the frontline setting, it's reasonable to consider either a TKI or atezo plus bev.
Absolutely. Thank you for reviewing both those recommendations and the level of evidence behind those. I think it's important that even in the areas in which the expert panel didn't have a lot of evidence to go off of, that there are still recommendations available for clinicians that are based on expert opinion. So then following those second-line therapy options that you just described, what recommendations did the expert panel make for third-line therapy?
So regarding the recommendation for third-line therapy, one of the things that we did want to make clear as a panel was that third-line therapy is a reasonable consideration in a subset of HCC patients. Quite often, 5 or 10 years ago, it was very seldom that a patient might be considered for frontline therapy because of the burden of toxicity and or disease progression during the first 2 lines. But now for patients with intact liver function and good performance status, I think it's very reasonable to consider the same list of agents that might have been considered for second line. And again, I think the general guidance here is if you've already given your patient both atezo-bev and some kind of CTLA-4 PD-1 combination, it's probably best to use a non-overlapping regimen, something like a TKI. If in the frontline setting you followed atezo-bev by TKI or durvalumab by TKI, then it would be reasonable to look at the immune therapy combination that the patient hadn't received yet. Unfortunately, again, at this point in the this is all at the level of expert guidance and personal experience, but just thinking about the mechanistic rationale behind these different combinations and which ones your patient has had the opportunity to benefit from yet is probably the best guidance that we can give as you move into the later line.
Definitely. Thank you for reviewing that guidance as well. So then these recommendations that you've already described refer to patients with Child-Pugh class A liver disease. What is recommended in the guideline for patients with Child-Pugh class B advanced hepatocellular carcinoma?
Thanks. And I think that's another important question, and it's a part of the field that's still evolving. So this is in some ways similar to the situation for third-line therapy. The level 1 evidence that we have in the clinical trials that were done were almost exclusively done in the context of Child-Pugh A liver function. But we know well that many patients with hepatocellular carcinoma have some degree of impairment of their liver function, making them Child-Pugh class B or beyond. Similar to third-line therapy, we do believe that it's appropriate to cautiously consider systemic therapy for these patients. Particularly a better compensated patient with Child-Pugh class B liver function may be considered. The same systemic therapy options that are considered for patients with Child-Pugh class A may be considered here, even to the level of considering atezo-bev or durva plus tremi. I will also acknowledge, though, that when considering the underlying liver function, the bleeding risk, portal hypertension, and all of the other issues that may be at play, it may end up being safer for clinicians to consider monotherapy with an agent like durvalumab or using a TKI by simple virtue of the fact that if complications ensue, treatment can be interrupted and the therapeutic will leave the patient's system relatively promptly. The key take home here is, please do consider for systemic therapy in this population, but also consider it with caution, with an understanding that the underlying hepatic dysfunction also plays a role in affecting the outcome.
Thank you for reviewing those recommendations for patients with Child-Pugh Class B advanced HCC and all of these recommendations, which are based off expert review of the evidence and consensus of the entire expert panel. So then, Dr. Gordon, in your view, what is the importance of this guideline update and how will it impact both clinicians and patients with hepatocellular carcinoma?
I think the impact of this guideline update was really to open the field and really just make clear that the use of CTLA-4 containing combinations was appropriate for patients with HCC because those data were not available at the time of the last guideline, and to try to provide some insight about where and when to incorporate them. We really think that these agents have the potential to significantly impact outcomes for patients with HCC, and so we wanted to be clear that these can be considered therapeutically even after frontline use of a PD-L1 inhibitor like atezolizumab. And so I think the key objective of this guideline is really to be enabling and really to make it clear that within the now somewhat surprisingly broad range of approved agents that we have for HCC, these options are on the table and may be used in succession depending on patient specific tolerance and their clinical course.
Absolutely. So then you've specifically mentioned that both the original guideline and the guideline update were developed to provide timely guidance from recently published randomized clinical trials. So what are the outstanding questions still regarding treatment options for advanced hepatocellular carcinoma?
I think those questions are really reflected in one of the things which is challenging about these guidelines, which is that it's a very kind of open set of guidelines. We provide clinicians with a range of options, but we're really not in a position to provide much evidence-based guidance around treatment selection beyond the sort of careful avoidance of contraindications. I think that there will continue to be drug development for HCC. I think there are more potent immune therapies that are currently in use for other tumors that are being studied here. And I think we do hope to see new agents in future guidelines as well. But I really feel like the key question is going to be starting to stratify patients for who's going to be most likely to benefit from exposure to an antivascular agent, who's going to be more likely to benefit from exposure to a more potent immunotherapy, so that we can give our patients the best medicine for them in the first setting, and that we're less in the position of having to sample the available options to see which one might work for our patient. And I think that that's going to require significant effort, particularly, honestly, in academic medicine, as these medicines start to get used to develop the kinds of data that will enable identification of biomarkers and mechanisms of response, as well as identification of efficacy, which has been this sort of key limiting step in HCC therapeutics for the last 10 years. Now that we've got so many effective agents, we would like to see them be more effective, but nevertheless, it's been huge strides forward. Then the question is who gets what when. I think the other place of interesting development right now is the integration of local regional therapies like embolization procedures, either chemoembolization or radioembolization, as well as stereotactic body radiotherapy with systemic therapy. My suspicion is that it's going to take a little bit more time before the use of these is really well understood and how they might fit into the current standards of care. But we're starting to see some large studies tackling this question. I think that we will see impact of the combinations of systemic therapy and local regional therapy in guidelines to come in parallel to a better understanding of which treatment is right for which patient.
We'll look forward to all of the future developments in the care of patients with advanced hepatocellular carcinoma and look forward to inclusion of all of those things that you just mentioned into guidelines in the future. So I want to thank you, Dr. Gordon, for all of your work that you've done to update these guidelines and for taking the time to speak with me today.
Absolutely. And I actually just want to express what a great experience I've had working with the ASCO Guidelines team. I think that this is very challenging work, and I really appreciate the professionalism and commitment that they bring to it. I think it has a huge impact, and I'm glad to be part of it.
Absolutely. And finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/gastrointestinal-cancer-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, which is available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.